discussed regarding the coronary artery disease, and next we have seen if it is progressed, the patient will be definitely complaining about the presence of chronic stable angina. Now we have discussed in detail about the chronic stable angina, what it is, and what other symptoms will be complained by the patient associated with the presence of chronic stable angina, as well as the diagnostic studies to diagnose the condition of coronary artery disease and their basic management. And also we have studied details regarding the preventive measures which generally used by a patient to manage the conditions and prevent the progression of this disease condition. Now also we have learned if this condition or the chronic stable angina is not getting a proper treatment, or basically we can say the underlying disease condition which is causing the condition or causing the development of chronic stable angina is not treated initially, so it will definitely progress to a severe disease condition, or we can say an advanced stage of coronary artery disease that is termed as the acute coronary syndrome. Now here we are today going to discuss regarding the details of acute coronary syndrome. Now, acute coronary syndrome, basically it is suggested when the ischemia of the myocardial layer of the heart is prolonged and not immediately reversible. So then the symptoms which are occurring in a patient basically will be including the presence of unstable angina and the myocardial infarction and related symptoms. That condition is known as the acute coronary syndrome. So I'll repeat once again, the acute coronary syndrome is termed when the ischemia of the myocardial muscle layers is going on a prolonged duration and which is not immediately reversible, or we can say if the myocardial infarction has already occurred, or if the treatment is not being initiated at early as possible, then we are going to see the effect of the myocardial infarction will be long, and it won't be a condition which can be reversible. That condition we are terming it as acute coronary syndrome. Now basically this acute coronary syndrome encompasses with a spectrum of disease condition, basically the spectrum of unstable angina, non-ST segment elevated myocardial infarction, or a ST segment elevated myocardial infarction. I'll repeat once again, basically the acute coronary syndrome, we are going to see the person will be complained about the presence of unstable angina. Along with that, there can be presence of non-ST segment elevated myocardial infarction, as well as there can be presence of ST segment elevated myocardial infarction. So basically, if you are going to talk about the myocardial infarction, we are going to say a person can have two type of myocardial infarction present. One is termed as non-ST segment elevated myocardial infarction, whereas the other is termed as ST segment elevated myocardial infarction. So I hope you are clear that these three disease conditions of unstable angina, non-ST segment elevated myocardial infarction, and ST segment elevated myocardial infarction will be generally present in case of acute coronary syndrome. Now, this acute coronary syndrome associated with the deterioration of a once stable atherosclerotic plaque. So I hope you are understanding the meaning of this statement. So basically, we have seen before the developmental stage of the atherosclerosis plaque, right? So we have also seen the person would be having a developed atherosclerotic plaque for so long duration. After a long duration, there will be presence of atherosclerotic plaque in the blood vessels, in the lumen of the arteries, which will be basically occluding the arteries of the coronary circulation, and ultimately will be causing the associated symptoms with the myocardial infarction. Now, when we are calling the condition as acute coronary syndrome, it is basically indicating a condition where it has been deteriorated, or we can say the atherosclerotic plaque, or the plaque which has been present in the coronary artery, which is stable, has been deteriorated because of some pathological or underlying pathological condition. Now, once this stable plaque would rupture, which will be definitely exposing the intima of the lumen of that localized area, will be exposing to the blood, and definitely there will be stimulation of platelet aggregation. Also, there will be presence of local vasoconstriction, and again there will be presence of thrombus formation. So I'll repeat once again, we have seen in the complicated lesion state that once this stable plaque which are present in a normal coronary arteries lumen, basically it is occluding the lumen of the arteries and interrupting the blood circulation through that. What will happen next? Because of certain stress, or because of the shearing stress, actually this plaque can be unstable and ultimately it can get ruptured. Now, as the age is progressing, as the plaque is having a rupture, now this ruptured plaque would exposing the underlying intima or of the blood vessels, which will be basically exposed to the blood. And we are going to see that in that localized area where the underlying lumen of the blood vessels is exposed, will be going under platelet aggregation. Even there will be presence of local vasoconstriction, as well as the thrombus formation also would take place as the plaques are having rupture, and there will be definitely presence of hemorrhage. So associated with that, there will be presence of thrombus. Now, this unstable lesion after the plaque has been ruptured, this unstable lesion may be partially occluding the coronary artery, or maybe it will be forming a thrombus which will be totally occluded thrombus. So I will repeat once again. Now, this unstable plaque, after the rupture of the plaque, there will be hemorrhage and thrombus formation. Now, this thrombus formation can be causing a partially occluded thrombus, as well as a totally occluded thrombus. Now, in case of partially occluded thrombus, which are a kind of thrombus which is present over the lumen of the arteries but exclude or occluding the arteries partially, it means that in case of partially occluded thrombus, there will be a more blood circulation will be present, though the blood circulation will not be adequate enough to meet the need of the myocardial layer of the heart, but the blood circulation will be taking place in case of a partially occluded coronary artery. Now, if partially occluded thrombus is present over the coronary artery, we are going to see the person will be showing the feature of unstable angina and a non-ST segment elevated myocardial infarction. So basically, the person would be complaining about the unstable angina, as well as the person would be complaining about the myocardial infarction, or the person will be present with a myocardial infarction which won't be associated with a ST segment elevation in ECG studies. Whereas if the thrombus is totally occluding the coronary artery, it means that it is completely disrupting or blocking the blood circulation to the myocardial layer of the heart. We are definitely gonna see the presence of ST segment elevated myocardial infarction, or we are going to see the person would be complaining about the sign and symptoms associated with myocardial infarction, and once the person is going under the diagnosis, we are going to find out the ECG changes will be showing a ST segment elevation associated with the myocardial infarction. We are definitely going to see the person will be complaining or presenting with unstable angina and a non-ST segment elevated myocardial infarction. Whereas in case of totally occluded coronary artery along with the thrombus, definitely the person would be showing the symptoms associated with myocardial infarction, and if diagnosed, we are going to see the ECG changes will be very prominently showing a ST segment elevation associated with this myocardial infarction. Now, basically, the instability of this plaque is basically caused because of a systemic inflammation which is affecting the plaque of the coronary artery. That is the reason why these plaques are getting unstable in nature, and we are going to see a person is showing lots more severe symptoms associated with this condition in case of acute coronary syndrome. So now we are going to completely focus on the signs which are generally present with a person who is diagnosed with acute coronary syndrome is unstable angina. Now you have to remember one thing: unstable angina is a kind of chest pain that is new in onset. Even it can occur at rest or while doing some activities and have a very worsening pattern, and which is basically not depends on the rest and activity mode. So I'll repeat once again, basically this unstable angina will be having a complete different feature or complete new onset even if the person is having a chronic stable angina before. So basically if a person is having a coronary artery disease, if it is a progressed stage, they will be complaining about a chest pain which is a prolonged kind of chest pain will be present, which we are basically calling it as chronic stable angina. Now suppose if a person has progressed to the disease condition of acute coronary syndrome where the person is complaining or having a unstable angina, we are going to see the person or the individual patient will be always complain about a different pattern of chest pain or a chest pain which is completely new in onset, and even it can occur at rest and will be having a worsening pattern. Whereas in case of chronic stable angina, we have seen that it is manageable with rest and with certain lifestyle modification and treatment. The chronic stable angina actually can be managed. But unstable angina will be having a very worsening pattern. Now, the patient with chronic stable angina may develop the unstable angina sooner or later. Unstable angina may be the first clinical sign of coronary artery disease as well. Now, before we have already discussed, the patient may not show the presence of chronic stable angina associated with chronic coronary artery disease. Now, maybe a person or an individual can directly come with the presence of unstable angina, which is considered to be the first sign associated with coronary artery disease. Unlike a chronic stable angina, unstable angina is unpredictable and it is considered as an emergency. So you have to remember one particular thing, that chronic stable angina is not having a very severe pattern, but here in unstable angina it is unpredictable in nature and considered to be as an emergent condition for any individual. The patient previously will be diagnosed with chronic stable angina, describe a significant change in the pattern of their anginal process. So generally a person who is suffering from chronic stable angina would be complaining about the complete changes in the pattern of their chest pain. That is when we are finding it out that it is a unstable angina. Now it occurs with increasing frequency and is easily provoked by even the minimal or no exertion. Even during sleep or resting time, a person can actually complain about the presence of unstable angina. The patient without previously diagnosed angina describe anginal pain that has progressed rapidly in the past few hours, that even can progress within days and weeks, and often ending in pain at rest. So in case of unstable angina, the person who have not suffered before with chronic stable angina, for them the unstable anginal pain course may be prolonged in duration and which will be often have a complaint about the onset of a rapid onset of chest pain within the past few hours or days. Now, basically, this unstable angina will be almost always present, associated with the other sign of heart failure includes the fatigue, the shortness of breath, indigestion, and anxiety even for the client. Fatigue is the most prominent symptoms. However, all these symptoms can relate to the many different disease as well and syndromes. So thus women will be presenting with unstable angina before even coronary artery disease diagnosis sometimes. So it is very unpredictable, and the condition has to be diagnosed in a very careful manner, because women will be often will be associated or will be presented with unstable angina directly even before the diagnosis of coronary artery disease. So we have to look for the associated symptoms which are present in the client, and always we have to go for varieties of diagnostic study to confirm the diagnosis of coronary artery disease. So I hope till here you are completely understood about the unstable angina. Now, one of the most important point to recognize and to understand and to remember is that once a person is suffering from chronic stable angina, they will be significantly see changes in their pattern of the chest pain as well as their duration and the initiation of it. So then only a person, if it is complained by an individual person about a complete changed pattern of their chest pain or a very severely worsening chest pain which maybe have a rapid onset, then only we may recognize it as a unstable angina. Next, if a person is present with unstable angina, we are going to see often that the person would be complaining about the condition of myocardial infarction as well. Now, what is myocardial infarction is, let us study now. So myocardial infarction occurs because of a sustained ischemia which is causing irreversible myocardial cell death. So I hope in previous session when I was discussing about the ischemia or myocardial cell death, we have discussed that till 10 minutes if the coronary artery is seized with the blood circulation, but after that if it is reversed or if the coronary artery arterial circulation is managed or maintained, then also we are going to see the myocardial cells actually will recover from their ischemic state. Even they can actually resume all the other activities like their contractility and the cell's metabolic state or aerobic metabolism inside that. But here we are going to see the myocardial infarction is such a condition where because of a prolonged time of ischemia, the myocardial cell death has occurred permanently. Now, when does it can happen? Now, thrombus formation will cause 80% to 90% of all the myocardial infarction. Now, when the thrombus develops, there is no absolute blood flow to the myocardial distal to the blockage, right? So that will be resulting in necrosis. So we have already studied that once the thrombus is formed into the coronary artery, what will happen? Definitely the coronary artery circulation will be disrupted. That is the reason why the blockage distal to that, the myocardial cells will be going under necrosis, because there will be no proper supply of blood, even the oxygen and nutrition will be lack there. So that is the reason why we are going to see the contractile function of the heart will be stops in this necrotic area, and the degree will be altered or the functional degree will be altered depends on the area of the heart involved and as well as the size of the infarction. So we are going to see basically that which area the necrosis has been occurred and to what extent the necrosis has been occurred. In very precise, the size of the necrosis will be determining the functional alteration of the heart. Now suppose the necrosed area is very small, so maybe we are not going to see a huge alteration in the function of the heart muscle there. But if the necrosis has been occurred occurred in various places and have a medium to huge size of area affected, then we are going to see the alterations of the functions will be very prominent for the myocardial layers of the heart. Now, the acute MI process or myocardial infarction process will definitely takes time. So, cardiac cells can actually withstand the ischemic condition for approximately 20 minutes before the cell death begins. So, as I said, approximately till the 20 minutes, if the coronary circulation is not providing any blood supply to the myocardial layer at all, till 20 minutes, actually the myocardial cell can resist the death or resist undergoing death. Once after 20 minutes also, the coronary circulation is not reversed, then we are going to see the myocardial cell will start begin with their death process. The earliest tissue to become the ischemic is the subendocardium. So subendocardium layer of the heart or the tissues of the subendocardium layer is the basic and the primary cell which are going to or which are more prone to go under death in the initial period after the 20 minutes if the blood supply from the coronary arteries is not reversed. Now, just to note it, the subendocardium is the innermost layer tissues of the cardiac muscle. Now, if ischemia persists or if the ischemia is going on present over that area, it takes approximately 4 to 6 hours for the entire thickness of the heart muscle to become necrosed. So I hope you're understanding in a very high pace the intervention is to be done and is needed basically for a client if they're having a partial or a complete occlusion of the coronary arteries. Now basically it is considered if a major arteries is completely blocked, it would take approximately 4 to 6 hours for the entire thickness of the heart muscles to become necrosed. Now, if the thrombus is not completely blocking the artery, the time of the necrosis for the whole length of the myocardium may goes up to 12 hours. So basically it depends on the which artery is blocked and what is the location of the thrombus, whether it is partially occluding the artery or whether it is a complete occlusion of the coronary artery. Depending on that, we are going to see if it is a partial occlusion of the artery, we are going to see the whole thickness of the heart can go under necrosis within 4 to 6 hours if the coronary circulation is not reversed. In case of a complete occlusion, we are going to see the whole thickness of the myocardium may go under necrosis within 4 to 6 hours. But in case if we are going to see a client is having a partial occlusion of the coronary artery, it may take, or the whole thickness of the myocardium to go under necrosis, it may take up to 12 hours or more than that. So I hope you are completely clear that this will take, or this whole process of the necrosis and myocardial infarction will take a long duration after the complete occlusion or cessation of the blood flow through the coronary arteries. Now, myocardial infarction usually described based on the location of the damage. So where the infraction has been occurred, depending on that we are going to name it. So there can be presence of anterior myocardial infarction, inferior myocardial infarction, lateral myocardial infarction, septal myocardial infarction, even posterior wall infarction of myocardium. So basically we are going to see depends on which coronary artery is blocked by the thrombus. Depending on that, we are going to see different location will be involved in the process of the necrosis and infarction. And depending on that, which necrosis or which location the necrosis and the infarction has been occurred, we are going to name the myocardial infarction, like anterior myocardial infarction or maybe a inferior myocardial infarction. even we can see sometimes the combination of both. So if the infraction is present both in the anterior and the lateral wall, we are going to name it as a anterolateral myocardial infarction. So here I have you are able to see the slides, I guess, where it is mentioned that because of which artery blockage or which kind of myocardial infarction we are, or which location we are going to see the infarction. So let us just see the slides prominently. Now, the degree of pre-existing of collateral circulation also will be influencing the severity of this infraction. So an individual who is having a very prolonged history of coronary artery disease will be definitely developing other collateral circulation to provide to the area surrounding to the infraction which side with the blood supply. Now, this is the one reason why the younger person may have more serious first myocardial infarction attack, because for them, for the younger person, we are not gonna see a prolonged presence of the coronary artery disease, right? So for them, the collateral circulation development is very less. That is the reason why a younger person would be suffering more severe symptoms associated with myocardial infarction. Whereas in case of older person who have a very prolonged history of coronary artery disease, for them maybe the symptoms will be less severe because of the presence of collateral circulation. So that is how we are going to see the presence of collateral circulation also will be influencing the severity of the symptoms for myocardial infarction. Now, the clinical manifestations include the severe immobilizing chest pain. Definitely, as there is infraction is taking place in the myocardial layer of the heart, we are going to see there will be severe immobilizing chest pain will be present, which will be generally not resolved by any position change or nitrate administration, even on rest. So I hope you are understanding. In case of unstable angina or even the stable angina, we have seen the position change, the proper rest, bed rest, removal of the anxiety and stressful environment, even the nitrate administration would be helpful to manage the chest pain. But in case of myocardial infarction, we are not going to see that the client will be telling about the resolvence of this chest pain, even if the position changes, if it is done, even with the administration of nitroglycerin, even with a proper rest. A patient would be complaining about a heaviness over the chest, a pressure, even the tightness they will be complaining. Even there will be sometimes the burning sensation, and which will be having a constriction in nature in the epigastric area basically. Substernal chest pain, retrosternal chest pain, and epigastric region will be having so much pain. The patient will be basically complaining about the pain over the substernal, retrosternal, even to the epigastric region. Now, this may occur because if the patient is at rest or active, in both of the time, the person can actually complain of this chest pain.